welcome you to our February In Touch with Experts that is presented by the Kangaroo Care Day initiative. Today we have Mary Coughlin. Mary is a person that I have followed for many, many years, and she is an inspiration to me and to many others. And her bio says she's an inspirational speaker, motivational coach, and transformational consultant, which I attest to all those three. She's a veteran of the United States Air Force Nurse Corps. Mary's clinical background spans over 40 years as a seasoned staff nurse, charge nurse, neonatal nurse practitioner, hospital administrator, and entrepreneur. Ms. Coughlin is currently the president and founder of Caring Essentials Collaborative. As a global leader in the neonatal nursing, Ms. Coughlin has published extensively on the topic of trauma-informed care for infants, families, and clinicians. Her scholarly work includes textbooks, book chapters, and peer-reviewed papers, and her work has impacted more than 20,000 clinicians from as many as 20 different countries around the globe. I want to welcome you, Mary. I want to also introduce Marie Boone-Clark. She is my co-host. Marie is a personal friend of mine that I met through my work with neonatology. I am a mom that has had a preemie baby 20 years ago. And my background is I have a PhD in ergonomics engineering, and I am a avid proponent of Kangaroo Care, trauma-informed care. One of the things that Mary didn't say is that she offers a trauma-informed care certification course for professionals, and I took the class or the program, and I definitely recommend it. I'm also the founder of Kangaroo Care Day and the CEO of Nurtured by Design and the inventor of the Zakis. Marie, you want to say a little bit more about you, and then we can start? You're muted. There you go.
Still admitting we are a large party today. Thank you, Jamila. My name is Marie Boone-Clark, and I am the co-founder and Chief Executive Officer of Antonia and Grace. And we are a subscription-based service that puts birthing people within an ecosystem of doulas, lactation consultants, nutritionists, etc. We are launching later this year, and our pilot was based in Atlanta, but I'm hailing from warm and sunny Scottsdale, Arizona. So glad to join Jamila, and welcome everyone.
So this series is presented by, like I said, Nurtured by Design. The Kangaroo Care Day, and we have a lot of parent organizations that join us. The Antonia and Grace is one of them. Nicu alumni, Jennifer Deagle, which is an author, NPN, which is the Nicu Parent Network, which I am part of, Preemie World, and Hands to Hold, and a lot of people that have helped us put this thing together. So Mary, I think you can, I stop my share and you can share, and we're going to do 15 minutes, about 10 to 15 minutes of presentation, and then we open it up for questions for everyone.
All right, awesome. So it felt important to just kind of set the stage for this talk. I loved all of the comments that were shared during the registration process, and hope we can really kind of dive deeper into that. But my talk today is looking at where is the love, and trying to get to the heart of trauma-informed care. Let's see if I can advance it. Okay, good. I can do it. These are the three kind of high points that I'm hoping to share with you guys today, to talk about the power of love to transcend trauma. And I feel kind of to segue into that, I'm just going to give you a little backdrop of what trauma is and the importance of this topic. And then we'll wrap up and transition to our discussion to talk about what does love look like in the NICU and beyond. There were several folks that were intrigued by, you know, the possibility of this concept in different settings. And holy moly, absolutely. Okay. I mean, I focus on Nicu because that's where my clinical competency lies. But this idea of trauma-informed care actually has its roots in behavioral health. And I think what we're learning now is that behavioral health isn't just this, you know, a silo over here. And, you know, if you've got some mental health issues, oh, you got to go over there to have it taken care of. That as whole integrated complex organisms, you know, our mental health can't be teased out of our physical health needs. And so absolutely, this idea has relevance across the entire continuum, from birth all the way to the end of the life spectrum. And then I'm going to really, you know, flip it over to you guys and talk about how parents can advocate for love in their hospital setting. So to just kind of set the background of this topic, and I mean, I'm sure folks that are passionate about kangaroo care, passionate about developmental care, don't really need a lot of biology and a lot of, you know, anatomy and physiology to understand the relevance of this topic. But I felt that it was important to just touch upon it a little bit so that, you know, when you're presenting your intention around this really relevant paradigm in your clinical setting or with your parenting experience, you can say, you know, there's biological support for this. You know, I'm not just this fruity tooty chick that's saying we should love everybody, although we should love everybody, but that there's actually biology. It's inherent in our survival to understand the relevance of love. And so in this image here that I share with you, on the right, you see this little kind of animation, it's not an animation, cartoon or a drawing of a brain. And what I think is really important for us to understand is that at the very base of our brain, this brain stem that I've kind of got a circle drawn around is really at the core of keeping us alive, right? It's that survival aspect of our biology. And this is how the brain develops, right? It develops hierarchically from the bottom and the inside out. And so for my non-clinician friends and colleagues on this call, it's just, I think, important for us to know that that survival mechanism is at the very beginning of our development as human beings. Okay, I mean, at the very beginning of pregnancy, this aspect of an individual's anatomy and physiology is hardwired. And then on top of that, right, as the central nervous system or the brain continues to evolve, then this other aspect of the brain envelops the brainstem. And that enveloping area is called the limbic system. And you can see that here on the image. And the limbic system is really all about memories and emotions. And it's informed by how safe we feel. The brainstem, that survival piece, is really about, am I safe? If I don't feel safe in any kind of situation, whether I am a premature person, a full-term person, a toddler, or a 63-year-old woman, if I don't feel safe, nothing else matters. I am not capable of listening to you, taking instructions from you. I can't create a relationship with you because I don't feel safe. And I think it's really important that we understand that at a core level, because a lot of times, I know from a clinician perspective, I'd try and talk people out of their fear, right? You can't talk somebody out of their fear. You have to love them out of their fear. And I know that might feel weird, you know, but how do you love somebody out of their fear? You sit down next to them, you hold their hand, you say some comforting words, you connect with them, you help them understand that you're not alone. I've felt afraid, I've felt anger, I felt, you know, whatever the emotion is. You have to create that bond, because without that bond, without that sense of being seen, of being cared for, nothing else is going to happen. I'm just going to be locked in here. And many of you as parents, you may have been told that, you know, clinicians were giving you information repeatedly over time, saying the same thing over and over again. And that's actually a normal part of a trauma experience. And what it means is that no one was able to get to that place with you to help you feel safe. And once you feel safe, right, then you have to examine, do I feel loved? Does this person really care about me? And once you have those two entities, again, wherever you are on the life continuum, if you are a teeny tiny baby born at 22, 23 weeks, if you don't feel safe, if you don't feel loved and seen, nothing is going to happen. Nothing good is going to happen. You're going to be overwrought. You're going to be overwhelmed. You're going to have this incredible stress response that's going to have negative implications for your health and wellness. And then this top part of the brain, oh, I apologize, I didn't do my little circle on the middle part of the brain. But then all of this like bubbly, squiggly part of the brain that you see on the image, that's actually the newest part of our brain as evolving human beings, right? The primitive piece is the brainstem. Kind of that mid-range is what's evolved over time as we've learned as human beings that relationships and connection are important to our survival. And then the last place where our brain has evolved is in the cortex. And actually more recently, the prefrontal cortex, which helps us, kind of interpret and translate our emotions and reason and rationalize with others and learn. But none of that stuff is open for business. Frightened, we're feeling isolated. Is that making sense, guys? Just wanted to kind of set that stage so that you could understand then, why is love relevant in our clinical work? Why is love relevant for me as a parent in a crisis situation? Where does love fit into here? Because maybe I'm just thinking about survival, keep my baby alive. And clearly that's important. But I want you to really understand that to have a full life is more than survival. Our goal collectively as parents and clinicians is to survive in order to thrive and flourish in our lives. And the way we do that, the way we thrive and flourish is through love. It's through our relationships. It's through our awareness of our shared humanity. And that, to me, that is at the base of trauma-informed care. Now, just for a real quick second, think about, as you look at this information on the slide, think about, does any of this information have relevance for you? Because the other thing that we know about trauma, now I specialize in looking at the trauma experience of hospitalization, but I also know that many people have had trauma before, that early life adversity, early trauma is actually pervasive globally, that it's over 60% in the United States will report at least one adverse childhood experience. And so why I'm bringing this up again, as we talk about love, we have to understand, yes, the baby is very important and we want the baby to feel loved and supported and secure, but we also have to understand the story of the family, of those parents, that this is probably not the first time they are encountering a traumatic life experience. And many folks who are survivors of trauma, because of our lack of attention on understanding the mental health needs of individuals who are processing trauma, who have histories of trauma, they might have just shoved it down, not dealt with it, not processed it. So they may not even know that there are remnants of trauma lurking within their psyche, within their cells. Because that's the other thing with trauma, is it actually creates cellular memories of these adverse experiences that have been sprinkled over your life. So when early childhood relationships are sources of overwhelming fear, or have absent, insecure, or disorganized attachments, what happens is the individual, these very young individuals, have to figure out, how do I cope with this? And the degree of their coping capacity is informed by their maturity. So the earlier these traumatic experiences happen, the more pervasive, right, the adverse effects. And so many young children, in an effort to cope, may develop these very unconscious views of the world. Don't trust anybody, it's not safe. Right? That first year of life is trust versus mistrust, trust from a psychosocial perspective. And if my early experiences were all very chaotic, unsafe, frightening, I learned that the world is a scary place and I can't trust anybody. Oftentimes you learn, don't reach out, don't be a burden to anybody else. Because what I've learned in my early trauma is that I can't trust, I can't rely on anybody. If I say anything, then maybe there's some adverse consequences, or nobody really cares anyway. So you just learn to stuff things, right? Don't dwell on how you feel, just move along. And many of these coping strategies, I'm using air quotes because they really are maladaptive coping strategies, they may have worked early in life, but they actually color how you move through the rest of your life. And again, that's why I believe that this is so critically relevant for us as we care for, whether we're parents or clinicians, as we care for these brand new developing humans, the relationships that we cultivate with them inform the rest of their relationships. There was one comment from a gal who completed her registration and talked about her child, who was now a 50-year-old grown-up, who never married, who moved back home after a certain time frame. And I'm not remembering all of the details of the comment, but we see that in survivors of early life trauma, medical trauma, premature trauma, that because of their experiences, they are unable to get into cohabitation relationships. They often don't marry. They often don't have children, because what they've learned is that relationships aren't comforting. They aren't a source of solace and love. They're a source of more insecurity and more anxiety. And who wants to sign up for that? And so, as you start, kind of settling in this idea of love, you can see that it's, it has deep meaning, deep relevance for the developmental trajectory of these amazing humans, right? These absolutely amazing humans that survive the most incredible tragic situations. But again, surviving is great as long as it sets you up to thrive and flourish. Early life provides a sensitive window for programming lifelong emotional and cognitive processing, and has a profound influence over threat processing and social behavior, depending on what the situation is. And there's, just a myriad, and I don't want to get too crazy, although it is easy to get crazy about it, but there's just a crazy amount of biology now, of science, where we're really understanding the implications of a lack of love, a lack of connection, a lack of a sense of security during these incredibly sensitive windows of brain development, of human development. And all of this is, interestingly, right? It's not mediated by more medicine, more technology. It has nothing to do with it. It has to do with, in the previous slide, I mentioned that it's about relationships. We are a social species, and we know loneliness kills. We see this in our elderly population, right? Oftentimes when one spouse passes away, the other spouse, from the loneliness, because that loneliness translates into toxic stress. Take that understanding that many of us may be familiar with, and now put it at the beginning of the life continuum, and think about these brand new human beings who have spent maybe 6 months in utero, creating this, really beautiful reciprocal relationship with their mom on the inside, and their other parent, right? Who might be talking through the belly and that relationship. And then all of a sudden, brakes get on, they're born prematurely, whatever medical catastrophe has now befallen them. And they are literally isolated. They are experiencing a level of loneliness that we can't even fathom because of that experience of that total surround sound of parental proximity, parental love, parental presence. And so it is the number one trauma experience endured by all newborns across all mammalian species is separation, maternal separation. So that right there is the beginning of this cascade that we as clinicians on the call, we need to recognize the intensity, the magnitude of that catastrophic event and do everything in our power to address it, correct it quickly, swiftly. And it's not the thing that like you, oh, well, as soon as you're stable, as soon as you're medically stable, then we'll do about it. Come on, guys, these are not mutually exclusive phenomena. It's not an option, particularly what we know now. There's no more excuses that we have to bring them together. It's both survival and thrive together. Biologically, it's mediated by oxytocin, vasopressin, dopamine, these other really cool system, right? When I'm feeling the presence of that loving, and I know that I'm being loved, I'm safe on some level. I'm feeling safe, and when that's all present, that informs me that I can get through these difficult situations with that love. And I know that there are some situations when parents aren't able to be present or have made a decision to not be involved in the rearing of that baby. Then that also raises the bar for the clinician and figuring out how are we going to meet these biologically relevant needs of this developing individual. You just can't say, well, hopefully they'll find parents and somebody will, come to the rescue of this individual. If you wait, it's, that expression, the horse is already out of the barn. We have to be responsive continuously. I just read this really cool article. I'm digressing a bit, but I'll get back on track. But it was really beautiful phenomenological study looking at NICU nurses' touch, the role of the touch of the NICU nurse in supporting the family and the infant. Think about the power of touch. To me, that is the vehicle, one of the best vehicles for us to present our love, demonstrate our love. You don't need words. It's actions, it's presence, it's silence. It's that opening up your heart and someone can feel that. And I want you to think about that, right? Because you've had those experiences at some point in your life where no words were spoken, but you felt the loving presence of another human. We have to cultivate that skill because I think too many of us, and parents have experienced this, believe that it's mutually exclusive, that it's one or the other. And it can't be. We have to bring them both together. We know that oxytocin significantly contributes to the development of a sense of security and social connectivity. It promotes, selective attention to the mother, right? As those bonding processes are really kind of unfolding. But it also plays a significant role through epigenetic mechanisms too. I mean, we are literally wired behaviorally, psychologically, and genetically for connections that preserve our integrity as whole human beings who survive, thrive, and flourish. We have to get back to this and appreciate this because, again, lives are being altered in the absence of this understanding that the biology of safety and connectedness is mediated by not just the physical proximity, but the emotional proximity. And there's been some really nice papers written by Renee Flacking, talking about this emotional and physical connection, that sometimes parents are present physically, but they may not be there emotionally. And it's up to us, collectively, right? As fellow parents and peer support professionals and clinicians, to be able to understand that, recognize that. Because it's not just, skin to skin care, kangaroo care. Absolutely. It is. I mean, I'm already giving you the end result of this presentation, because that's how you do love, right? You do kangaroo care. But again, it's not a checkbox, because you could put a baby on my chest, my bare chest. You can make it look really nice, but you have to assess, am I present? Am I mentally and emotionally and spiritually present for this encounter? Because it's not just, it's not just an action, it's an experience that you're creating. And so a big part of assessing and bringing love to these critical situations is being able to recognize, is love present? Is it fully present? What are the needs of this parent? Have I supported? Have I been able to recognize that I think they're traumatized and they're going into a fight or flight response, maybe a freeze response, and I'm doing whatever you're telling me to do. Go ahead, put maybe, right? So aware of the breadth of this. And one of the things that I thought was really cool, a reminder as I was preparing for this talk, was that our noses, and you're going to love this, Jamili, that inside our nasal mucosa are oxytocin receptors. That middle part of the brain, if you remember that image that I had of the brain, that middle part of the brain is the olfactory bulb in the hippocampus, right? The amygdala, the nucleus accumbens, all these other really cool parts of the brain that are responsible for translating the sensory experience to that love awareness. So you can actually smell love. You can also smell the absence of love. Right? That's one of those primitive reflexes that help us navigate a situation. Many of you folks on the call that had that Nicu experience as a parent, I'd be interested to understand, what was the experience if you ever went back after discharge, if you ever went back to visit, because we would have parents come back and visit and stuff, and what that experience may have been like. Oftentimes it's triggered certainly by memory, that's initiated by smells that you may not even be aware of on first blush. That the elevator, when the elevator doors open on the floor of the NICU. All of that is, it is important for us to recognize the sensitivity that we have to these experiences, so that we can then figure out, what does love look like then? How can I create that experience that helps these individuals, babies, parents, partners, feel safe in the situation? Actually, in behavioral health now, there's studies are kind of 6 of one, half a dozen of another, but they actually give people intranasal oxytocin to try and help calm that jacked up autonomic nervous system, right? That jacked up stress response. People that have kind of chronic states of anxiety can take oxytocin intranasally to try and calm their nervous system down. And that's what oxytocin does. You can see this image here on the left. A lot of this oxytocin physiology facilitates what we call attunement, attuning to the other person. And it's not just a mother-baby attunement. I'm attuning to you guys right now, which is interesting, right? That we've developed this skill of attuning in virtual environments. But we have to, right? We have to kind of figure out, how do I connect with people? How do I make sure that I'm safe by attuning to you and meeting your needs, right? In this information situation, but even, like if I'm doing an admission in the NICU, how am I attuning to the situation? And this is a new skill, because I didn't attune. When I was a young NICU nurse, It was all about doing all the things. I wasn't attuning to the situation. I mean, I was attuning to the medical situation, but I wasn't attuning to the holistic situation. And as peer support professionals and mentors for individuals that are going through the crisis, we have to attune to them, because that's how we make those connections that have value, that bring our love to the situation, that helps the person feel seen, feel valued. And we know from research, and I don't even know that we need to have research for this, but people love to research stuff. So, okay, fine. We now have evidence that the human heart seeks relationships from conception. We know this. We know there's now really cool papers that look at the reaching movements of a newborn baby, even a premature baby, those reaching movements that may look kind of floppy and not very coordinated. Those are intentional movements of connection with other. If you think about the baby in utero, those movements, the baby, I mean, it was a secondary benefit that they were developing their biceps, that they were, creating articulation, successful articulation in their joints. But what the fetus is actually doing, what the baby is reaching to touch their mother. It's an intentional, embodied activity that continues postnatally, right? Your babies, they touch your face, they grasp your finger. And we say, oh, it's a reflex. Yep, it is. It's a reflex that creates connection. It's an intentional reflex on the part of the baby to begin the connection, the relationship building. It's not a mindless act. It's an intentional act that arises from that midbrain to create that relationship, because I know I will die without a relationship. We die without a relationship. That's how important love is, because what we know is love creates that capacity to be resilient. If I have somebody in my life that loves me, that cares for me, that will protect me as best as they can, I can get through the scariest shit in the world if I have that relationship. And that's what love does. And I know some of my NICU colleagues would be like, well, that's for parents. That's not me. I'm the nurse. I'm the technician. I'm doing these things. Are you kidding me? No, we are all part of the ecology. And I liked, Mary, you had said this earlier, Marie, you had said this earlier about your ecosystem thing. And these babies are being cared for in an ecosystem with other humans that create that social ecology that help this little individual learn that the world is either safe and secure and loving, or it's not. It's, scary and isolating and all that kind of stuff. And so you are a critical part of that, whether you're the nurse, the therapist, the physician, the peer support mentor, the friend, the grandmother, the partner. We are all part of this ecosystem, and that these supporting networks help us overcome adversity, and, beating a dead horse, help us thrive as human beings. And so, I'm wrapping up my slides now to open up for a discussion. It's, to start thinking about, what does love look like then in the NICU and beyond? And it's not just one person who's responsible for the love. It's all of us. And if you look at some of the work in burnout, you'll discover that one of the things that contributes so significantly to the burnout of clinicians is that we distance ourselves from the shared humanity with those that we serve. If we reconnect, and it feels uncomfortable, I get it, but if we lean in and we reconnect with our humanity, it actually fills our cup up. It helps us reconnect with our purpose, our passion, and our mission in life. This image you can see over here, I know it's a little bit abstracty, but I thought it was really appropriate, because here on the top is the brain, and it's a lotus blossom here in the middle, and then underneath that is the heart. And I think a lot of us get trained this way, right, as clinicians, and maybe as professionals in any environment, right? We don't need you to bring your heart to work. We need you here because you're smart, you're technically proficient, and you can do X, Y, and Z. But what we're learning is babies are surviving at smaller and smaller gestational ages. Why? I mean, I think a lot of it is because of our brains, right? And we're coming up with new technologies and all this other kind of stuff. But the outcomes of these individuals remains the same. That the majority of these individuals are highly at risk for adult morbidity, mortality, developmental challenges, psychopathology, depression, anxiety, adolescent suicide as a consequence of premature birth. So even though we're getting more and more people to survive, we're not really doing much to impact the quality, the thriving and the flourishing of their lives. And for me, that's because we have an integrated love into the care that we provide consistently and reliably. Because I know everybody here, we love these people. I know we do. But we have to get the courage to step up and step out of line and love out loud, care out loud, make it a standard authentically.
This is Kangaroo Care, first time.
Most van először rajtam kicsili olyan jó érzés. Így is kezdtem itt nem alig. Olyan jó. Alszik a kicsike olyan nyugodtan.
His eyes were open a few minutes ago. They said that he might take a while to calm down on mommy's chest, but he calmed down right away.
Yes.
1 hour at least. They're gonna hang out together. Get used to each other. All right, little Leo. Step by step every day. Going in the right direction, buddy.
Whoops, okay. All right, on that note, I'll stop my slide share and just open it up. Jamili, guide me.
Thank you. My goodness, this every time I listen to you is it's transformational for me, and I don't know what everybody feels. I think you can write your love to Mary on the chat. I think we're going to open it up for questions. This is a conversation with Mary. So if you look in the bottom of your Zoom screen, there is a reactions button. If you can raise
Okay.
your hand, then we can call you. And I think Mila,
Yes.
if you can say your name,
Mila Golovin, and
Mila.
the reason I'm interested in your talk is my business is we provide interpreters for healthcare settings,
Mhm.
and one of the things we do is we also train interpreters how to be better in the medical setting. So I'm very interested in how can, when communicating through an interpreter, whether with a deaf or hard of hearing individual or limited English proficiency individual, sometimes that message of love gets lost. What can interpreters do, or how does it present a challenge? Or have you thought about it?
Yeah, I did. I remember seeing your question on the list and thought, wow, this is really brilliant, that you're interested in exploring and understanding this. I think based on my experience with interpreters, I think a lot of times it's factual information, which is absolutely important, right? The facts are very important information to be communicated. But I think also, the urgency for parents to really understand the critical role that they play in the care of their baby, right? I mean, that it has to be communicated. They have to really understand that. And so I wonder if, having individuals that are interpreters really understand, this idea of trauma-informed care may actually help them ask the questions to the clinicians, during the exchange about, the presence of the parents. How does the unit support skin to skin? other types of things that I think the more that you know, the more that you can ask those questions of the clinicians, or at least start to have the discussion in how do we become a trauma-informed center then, because it's out of right. The interpreters are there and they're translating that information. You also want those that doesn't put the clinician in a bad place, right? That the clinician question taking a step behind, before that direct interpretation to discuss, where is our unit with regard to addressing this, with regards to engaging the parents and integrating them and partnering with them, across the entire experience from the beginning to the end, so that everybody understands what the expectations are. Does that make sense, Mila?
Yes, yes, and thank you. Let everybody else ask their questions too, but I want to connect with you. You can provide your email maybe in the chat for more
Sure.
questions.
Her email and information is in the email that I sent, the original one, and in the website is also in there. But I think that applies to anybody that talks to babies, right, Mary? I mean, not only if you're translating a language, but the way that we talk to babies, to parents, or to is important. MBM, I'm not sure what your name is.
Maria.
Maria.
Sorry, because it was a short one. Hello,
Welcome.
thank you. Hello, Mary. Thank you, and Yamil. I hope the pronunciation is correct because I'm Spanish, but I will try to. Yamile. Okay. Thank you. So thank you very much, first of all, because the speech was wonderful. Your training is amazing, and just to let you a little bit my background, I'm working in a company that is selling medical products from the Nicu. So we are teaching a lot to the nurses and doctors, and we have been training them since a lot of years ago in order to improve developmental care. So we are really, really focused in every speech, even though we are working with a cerebral monitoring, and for example, and in every, yeah. And with a Natus, it's in fact a US company. And in every speech, we talk about developmental care. We are in Spain, we are going step by step. So there's more and more NICUs that are opening, creating a space from the parents to live with the children together while they are in the NICUs. And so, but I'm facing two kinds of people. The people that absolutely understands directly and work directly for it. And I'm facing also the other people that it's a little bit more concerned about, and they need, like, as you said before, they need a test, they need proof, they need. So my first part of the question is, can you provide us maybe with some clinical studies like this I can share with the most dinosaurious doctors that I'm finding more stick to the,
Yeah, absolutely. Absolutely. And I think, I mean, I just written a second edition to this book called Transformative Nursing in the NICU, talking about trauma resource. Just recently, just in August of 2021, just a few months ago, the American Academy of Pediatrics put forth a clinical report and a policy statement about trauma-informed care for child health services. So I'm happy to do that, Jamila. I have a little bib that I can share with you, and maybe you could share it.
Yeah.
On the call, if that would be helpful.
We will send the link to this recording, and also the documents and handouts that you want to use.
Thank you. And my second part of the question is, I have a sister that is adopted since, and she was premature. She had a biological mother that was under drug consumption and alcoholic during the pregnancy. So she has a lot of illness in the brain.
Yes.
What do you think? Because what can we do with this kind of babies that they are not receiving love in the first beginning of their lives?
Yeah.
What can we do with them? How can we manage once they get out to the hospital?
Yeah, it's a very important question. It's a very complex question, because the other piece of the puzzle, Maria, is that the mother, the biological mother, I mean, I don't know her story, but what I know from the science is that the majority of people who do have drug use, you know, and and so you know, being trauma informed invites us to then understand that trauma history of the mother as well. And when we can do that, oftentimes you can create this transformational experience for the mother. You know, when the mother is embraced and loved and supported and respected and understands, you know, that her own trauma has brought her to this place in her life, that sometimes having a baby, even if they're premature, becomes a redemption, you know, a total redirection. But so that's one aspect. The other aspect, and I've actually had conversations with other clinicians about the nurses or the therapists offering skin to skin encounters for these babies that don't have families, immediate families, during a hospital stay. And there's several studies that have looked at the safety of skin to skin with non-related females. That's all they've studied right now. It doesn't have to be a female, but that's what the studies are, to offer the babies that sense of love and security. Because the more time that goes when the baby isn't experiencing love, right, the more the brain is adapting for an existence of isolation, right, and a distrust of the universe. So the closer you can bring those experiences of love and compassion and kindness, and I believe a lot is accomplished through skin to skin care for sure, then you might actually mitigate some of the negative consequences of that loneliness and that separation.
Thank you very much.
Oh,
Thank
you're
you.
most welcome. Excellent questions.
We have a question from Lisa. Actually, there are a couple of people talking about the same thing. So I'm gonna write Lisa, unless Lisa, you want to unmute yourself and ask the question. Okay, so she asked, how do you convince nursing staff that parents can safely hold their baby with umbilical lines and intubated? Our
Yep.
policy is very liberal with KC, Kangaroo Care, but we can't get staff to assist the parents when the baby is intubated or has an umbilical line. This sometimes makes it 2 to 3 week period of time before the parents can hold their baby.
Oh, I'm so sorry. That's a great question, Lisa. And I understand and I know that frustration, right? But I'm going to challenge you to just kind of come back to the thing that's holding them back is fear, right? They're concerned about the safety. And so what I've done in the past when I've worked with clinicians, I've built this kind of a step-by-step process of building their confidence and competence. Initially by using a mock-up. So getting a doll, putting tubes and lines, you know, put the intubation tube in the doll, put lines, you know, from an umbilical cord, just mock up the doll, and then go through the process. It's very slow step-by-step process. I think the other thing, and Jamila, I hope this is cool that I say this, but you have to have a safety device to, you know, to support the skin to skin care. And the product that I've used, it has been the Zaki. Because I think it meets all of the safety requirements that can address the clinician's concerns about doing the skin to skin. Because if you're using blankets and stuff like that, yeah, it's scary, you know, but if you have a secure process and it's a competency, right, with a mock-up return demonstration, And then you don't, if I've never done skin to skin in an intubated baby with an umbilical line, don't start me there.
Yes.
Start me, right? Start me maybe with the baby who's on CPAP and might have a PI, a peripheral IV. Start me there. Start me in a place where it's not a big giant leap of faith, but I can build my confidence in an intentional way, right? I mean, craft the competency. But I've found that that is super effective. And actually, I got to work with a group of Nicu clinicians in Portugal, and we wrote up the paper. So I'll add that to my bibliography for you guys. I should probably be taking notes, but I'll remember.
Mind you, I'm taking notes.
Thank you.
Thank you, Mary.
You bet, Lisa. You bet. So glad you're here.
Yeah, so with Kangaroo Care, that is so right. Usually when babies are on the bed, they have total control of the nurse has total control of the safety of this baby and the responsibility. But when they move the baby out, they're giving that control to the parent, and the parents often are sleep deprived. They're tired. They're totally like scared. And that's why, that's why I engineered the Zaki Sack, is to give that control back to the nurse, that the baby is safe, and then the parent can be calm, because they always told me, whatever you are, the baby's feeling it. Whatever you feel, the baby's feeling it. So if I am stressed out by holding the baby, then the baby, we're not going to realize all the benefits of Kangaroo Care. And I'll share a link of the
Cool.
research also for
and the competence thing too, Jamil, you reminded me, is for both, right? So it's the nurse and the nurse, one nurse pretending to the parent and the other nurse being the nurse and facilitating it, because then you can really see, oh my gosh, now I get it. This feels much more safe. But you do the same thing with the parents.
Exactly.
Go ahead. I'm sorry.
No, go ahead. You're saying exactly what I was going to say.
and then you do the same thing with the parents, right? You get a class together and you bring all the parents, and everybody has their Zaki on, and everyone does a doll. And then they can ask you questions about the process, and then do it in a super safe way, because who wants to drop their baby? Nobody. And so you want to build that confidence and give them the chance to ask those questions, and then you give them a beautiful little certificate of achievement or whatever, that it's like, this is going in the baby book and I am ready to skin my baby. So making it a thing.
I love that idea. And actually, Denise Morrissey makes a great point, because as you were talking, Mary, I was thinking, where was I the first time I saw someone do a practice with the doll? And it was with Dr. Jennifer Arnold, when she was still at Baylor Texas Children's, and she did simulation. And that's what Denise brought up in the chat, was that simulation labs can help with creating that confidence level for the nursing staff. And I love your idea of taking the doll and having mom practice with that first. I mean, that would be such a confidence builder.
Oh, yeah.
Poor Nancy has had her little virtual hand up for a minute.
I don't see that.
Nancy, are you still there?
Hi, Nancy. Oh, you have to unmute yourself, Nancy.
I can't see her.
Oh, hello, it's me.
Oh, hi.
Hi, Mary. How you doing?
Hi, so great that you're here.
Yeah, I love everything that you said. It just warms my heart every time. And every time I see Emil, I think of when we first met. But one of the things I just want to throw in as from the staff side, from the professional side, and having about 40 some years of experience in the NICU, I really think, and I love everything that the parents need everything, and everything that you said is exactly true. I do think that there is not enough support for the staff in the NICU. Taking care of these babies can be traumatic for the staff. Absolutely. Unfortunately, some of our babies do die. For some of our especially younger nurses, that's the first time they've confronted death, period. And babies aren't supposed to die. We see these babies struggle like little warriors, and we know that a lot of the things that we're doing are causing pain and discomfort. And sometimes our hands are tied because we're not real sure about some of the all the pain medications that we might be able to give to an older child. We're not real sure what this could do to the long-term development of the little ones. We're trying to support the staff our fellow staff members were trying to support the families. And I think what I have noticed is after a certain number of years, you see new grads come in and new nurses, and they're all excited about taking care of babies. And then something happens and it's extremely traumatic for them. And oftentimes when a nurse takes care of a baby that dies in the unit, they take care of the baby after death and they come right back to the unit and pick up another assignment.
Yeah.
There is no time to grieve. There is no time to get in touch with your own feelings. You stuff it. And then what happens is you stuff it, as you said, Mary, you don't deal with it. And then things become a task because you don't want to get hurt. It's not intentional by any means,
Right.
but it's a coping mechanism. And so then you have staff who have a difficult time then reaching out to the parents, and it becomes a vicious circle.
Yeah.
And so I think it's an area that really needs to be addressed as well, is support to the staff members.
Absolutely, Nancy. And I think, when we talk about the love, it is love of each other as well, right? And I think what somebody just said, but what COVID has taught us, I mean,
Yeah.
COVID didn't break the healthcare system. The system has been breaking for decades. COVID was just the straw that was, broke the camel's back. It was the last thing on an exhausted system that is not serving the humans that work for the system. And if it doesn't serve those individuals, then they are less capable of serving those, the patients, right, and their families at their highest capacity. And so I think what you're bringing up is really, really important, that we need to really shift the paradigm, not just at that patient interface, but across the entire system. And I think that's what, the Academy is trying to, start introducing with this policy statement for trauma-informed care. It's certainly part of the work that I do about trauma-informed care. Begins with the clinician and recognizing what they need, because you cannot give what you do not have. I have to read this little quote then from this book that it says, wherever we are, whatever we're doing, there is always the chance to reveal the inner. And she's referring to our compassion in our heart, to shed that light, to share our warmth and love with a shivering soul. And that shivering soul can be anybody else, right? I mean, and I think that's what I'm getting from you. And that's what we need to do. We need to begin to recognize the responsibility that we have to shift the tide, to change the existing, because what we do to care for ourselves will benefit the patients and their families, as long as it is guided by our purpose and our passion, guided by our love and our commitment to serve those in crisis. So I love what you said, Nancy. Thank you so very much for bringing it up.
I think in summary, everybody is a human, and we need to treat everyone as humans. Just because a baby doesn't say something or the parent doesn't say something, that doesn't mean they don't have anything to say. Exactly. So listening to that, to what the babies are saying, and we did this session last month about, communicating with the baby and respecting their space and respecting that they're humans. And you don't go to an adult and raise the foot and put a needle. Well, don't do it with a baby either. Just be gentle, be just be human with these humans.
Yes.
And nurses and therapists, those and doctors and volunteers and the administrative staff, you see trauma every day.
Yes.
And we appreciate that. And this is one of the things that we wanted to do, to also educate parents that, we are all humans.
Yes.
So Mary, do you have any last word?
I mean, the only thought that came to mind when you were sharing that, you said that so eloquently, is that, and we all bring our own trauma story to our, to the work that we do. So we have to honor that. We have to recognize, where are my wounds? Where are my tender spots? And know ourselves, so that in knowing ourselves, we can then metabolize our own stories and bring our better selves. And it's not like a, checkbox. Okay, I did that yesterday, I'm all set. We're always evolving. We're always growing. We're always being reminded of our shared connection with our fellow humans. So yeah.
I wish we had 3 more hours. Just starting. Mary, Marie, you have our announcement for next month
Oh my
before
gosh.
we finish
I
with Mary and
Yeah. Thank you, Mary. I want on a mug, we need to have a mug that says love them out of their fear. I will buy the first one. And a poster.
I think
So
we
much of what
definitely, yes.
so much of what you said, we need to commit to memory. And Nancy, you are my new hero. I'm going to stalk you because you make a beautiful point. I am not a clinician, but I've spent 3 decades stalking them and following them around the unit. And I remember the first time we had a loss. And I say we, and I was with one of my clients, and I remember the first time there was a baby, and I remember the child's name, the family, and I remember the first time I was with her, a friend who's a perinatologist, and we lost the mom, and that was several decades ago. So I can't imagine doing it more than one time. As for next month, we are going to shift gears a little bit. We are excited to have a brilliant nurse and lactation specialist joining us from Southern California. And we're going to talk about the golden hour and the life-changing importance of human milk, and how we can better support our parents as they go through the nutritional journey. So stay tuned for the announcements on that. And then in March, we have Dr. Christina Valentine, who is a neonatologist and has done a lot of work on human milk composition and the importance of fatty acid profiles. So, and then of course in May, we will celebrate Kangaroo Care Day, and we've got a lot planned around that. So stay tuned.
Thank you, Marie. Well, Mary, we are so thankful. Everybody's giving you love through the chat. And we will have this recording available within 1 week. And then we'll also give all the handouts. So thanks everyone. And I look forward to seeing you again. Thank you for joining us from all over the world. This has been an amazing session. Thanks,
Bye,
everyone.
everybody. Thank you so very
from
much.
the UK. I love that.
Thanks, Jamile. I appreciate
I'm
it.
gonna stop the recording, and you guys can stay.